Hello, Behind the Knife listeners. We are back with you. This is our last episode. Oy. Tonight, we're going to be discussing our last journal club in colon and rectal surgery on hand assist laparoscopic surgery with the Leahy colorectal surgery team. We opted to not do a special guest for our final episode. It's just going to be the core three of us breaking down these articles for you guys, highlighting the use of HALS. Providing some tips and tricks and when it can come in hand.
There you go, John.
That was Dr. Aulet. Good job, Dr. Aulet. Very nice. Yeah. All right. So today we're going to tackle some articles that are really central to the discussion on the use of hand assist in colon rectal surgery. So there's lots of ways to approach a case. We feel that hand assist laparoscopy is a very, very important technique. It's near and dear to our hearts here at Leahy. And so we wanted to end our time here with Behind the Knife to really go into the literature on its use and its benefits. And so one of the articles is by none other than our own Peter West Marcello, randomized prospective trial comparing HALS and laparoscopic surgery. And then the other article we're going to go into is laparoscopic colorectal surgery for obese patients and decreased conversions with the hand assist technique. So welcome to the team, Dr. Peter West Marcello, Dr. Tess Aulet.
Hey guys, it is really great to be back. It's springtime, the national meeting's coming. We just had our New England colorectal meeting, which was awesome. But this has always been sort of a special place for us to sort of talk and engage, and really enjoyed working with this team. Phenomenal work. I got to say, I've had the easiest job because I just come in and make the comments here and there, and Tess and John deserve the credit for doing the yeoman's part of the work. So great to my team here for their help. Tess?
Yeah, I mean, I can't believe it's already been 4 years that we've been doing this. Gonna miss it for sure, but I'm really excited to hear some new content by some of the new teams.
I remember when we did our audition in my office.
Yeah, I was still a fellow, and we huddled in your office and made a recording, and the rest is history.
The rest is history. All right, so we talked about how HALS has a lot of relevance to the Leahy team. So it does all start here for us, at least for me and Peter, with me and Tess with Peter and some of your background on HALS. And so can you prime the audience a little bit about HALS and your experience with how you came to it?
Yeah, and I think you really have to go back to the mid-90s when laparoscopic colectomy was just starting, and really realize, again, as we've talked in other episodes in different areas, that the challenges of doing a laparoscopic colectomy from open. It was phenomenal. Just doing a gallbladder was hard. You had general surgeons who were doing gallbladders, but don't do many colectomies. And you had colorectal surgeons who were doing plenty of colectomies, but didn't do simple laparoscopy. So when the colorectal surgeons tried to do this complex procedure, they couldn't really get a handle on it. And so we started with Dr. Milsom. I started doing laparoscopic colon courses, teaching the general surgeons and colorectal surgeons across the country. And the adoption was poor. Like, we would bring 10 surgeons to a lab, maybe 2 could pick it up. And what we found was that for the colorectal surgeons, they didn't have the skill sets. And for the general surgeons, they didn't have a clear understanding of the anatomy. And then putting a hand in allowed the colorectal surgeons to have better laparoscopic skills because of proprioception. And for the general surgeons, it allowed them to sort of feel more comfortable with the anatomy, even though they had laparoscopic skills. And so when we started doing hand-assisted courses to teach and train, we had about 70 to 75% adoption with this technique. And so the hard part was, while I thought that it was a good procedure, and we did studies, we couldn't really convince the zealots, those that were doing laparoscopy, that it was really a minimally invasive operation. So we really needed a trial to show that there were some unique advantages for the hand in terms of time and conversion, but it wasn't really going to change much of the outcomes. And so I'll talk, after we talk about the study, I'll tell you a little bit about how we went about it.
Nice. All right. Well, that was a great introduction. Tess, do you want to kick us off?
Yeah. So I'll be And if you're watching along on YouTube, I pulled this off the interweb. You can see a picture of none other than Dr. Marcello doing hand assist laparoscopy right there on your screen. So I'm going to be heading off the first paper. This was a multi-center study with many leaders in the field when it comes to both laparoscopy and colon and rectal surgery. The purpose of the study was to compare the short-term outcomes after hand assist laparoscopy versus straight laparoscopy. And the authors hypothesized that operative time would be shorter for the hand assist group or the HALS group while maintaining similar clinical perioperative outcomes. The study was done at multiple centers. There were 5 centers that participated with a total of 11 surgeons. It was a prospective randomized trial where patients who were planning to undergo elective laparoscopy, they focused on 2 procedures, either a sigmoid and left colectomy and then a total abdominal colectomy. The surgeons and sites were selected because all of these surgeons and centers were experienced in both hand assist as well as straight laparoscopy. One of the things I thought was nicely done, the conflict of interest was clearly stated in the paper. This is not industry-led. The investigators initiated this trial, but was industry supported. The procedures were chosen, the total abdominal and sigmoid colectomy, because they were felt to be both well suited for both approaches, whereas a right colectomy, sometimes your hand gets in the way because of where the camera would normally be. So again, they focused on the procedures that would be well suited for both approaches. Patients who had other procedures in the same operation were excluded that may impact timing. Emergency procedures were excluded, and patients who were not suitable for a laparoscopic approach, if they had dense adhesions or significant cardiopulmonary disease. Patients were then randomized into either hand assist or laparoscopy, straight lap, and then patient data, inpatient and post-op data was collected. The straight laparoscopy group performed, usually had 4 to 5 ports, and an extraction site could be anywhere in the lower midline, phalansteal, or the left lower quadrant, and could have an intra or extracorporeal anastomosis. They define hand assist laparoscopy, typically a 7 to 8 centimeter lower midline or phalansteal incision to accommodate a hand device, and then usually additional 3 to 4 trocars. Conversion was defined as any modification to any extraction site, and thus the straight lap group could convert to hand assist or to open. Post-op care was standardized, and the diet was standardized across institutions. The pain control was standardized with PCA and Toradol at the surgeon's discretion. They did track post-operative narcotic use as well as patient pain scores. Patients were not blinded to the technique that was used. The study tracked the operative time for left colectomy and skin to skin, and this was done skin to skin. For the total abdominal colectomy, they measured the operative time in 2 ways. They did do skin to skin, but then also looked at the skin to the mobilization or devascularization phase, which I thought was really smart, because obviously after you do a total abdominal colectomy, there's a lot of variability in terms of what steps might come next, whether they had an endoleostomy, obviously is quicker than a proctectomy with an ilioanal pouch. So again, they controlled for that in terms of the operative time. The study was powered to detect a 30-minute difference in OR time between the groups. There were 47 hand assist patients, 48 lap patients, with good and equal distribution between the left colectomies and the total colectomies. They were equal in regards to sex, age, BMI, history of prior surgeries, diagnosis, and why the procedure was being performed. Another thing they controlled and tracked was resident participation in the case as well. They found no significant differences in the procedure performed, intra-op complications, or resident participation. However, the mean operative time was significantly less in the HAL group for both sigmoid colectomy 175 minutes versus 208 minutes with a mean difference of 33 minutes, and also found a decreased operative time in the total abdominal colectomy group with 127 minutes versus 184. So that's a mean difference of 57 minutes. So that's a good chunk of change there. There was a statistical difference in the intracorporeal anastomosis happening more commonly in straight lap, 61% as compared to 14, but this was not statistically significant. There was no difference in return of bowel function, diet tolerance, length of stay, pain scores, or narcotic use. There was 1 conversion in the hand assist group and 6 in the straight lap group. Most of these conversions in the straight lap group were to hand assist, and again, not statistically significant. Overall, the authors concluded that hand assist laparoscopy had significantly shorter operative times while maintaining similar outcomes, despite controlling for a lot of factors, which I thought they did quite well. I found a few things interesting in this paper. One of the differences in technique for hand assist, which was kind of alluded to a little bit in the paper, was, how the hand port was used. There was difference between different surgeons. Were you using your hand to retract? And then the other person was using 2 hands to do the dissection. Was the hand helping and then the other hand was dissecting? So it was interesting to see some of those differences that were mentioned. The other thing that was tracked was the number of hand exchanges, and most of the procedures had over 10 hand exchanges, yet they still had decreased OR time. And so again, this kind of alludes to the benefit in terms of helping to facilitate teaching and being able to switch operating surgeons. While they were not powered to detect a difference in terms of the conversion rate, again, they did show a decreased rate, and hopefully using HALS can decrease the need to convert to a formal laparotomy. So I think this article and my findings in practice mesh well. The times I am using hand assist are usually for dense inflammatory conditions like bad IBD or diverticular disease, obese patients, typically when I'm taking the mesentery to be able to have a hand and feel and make sure I'm really getting a good high ligation. And so one question, I'll pose 2 questions to Marcello here to kick off some discussion. But in defining the intracorporeal, extracorporeal anastomosis and the difference there, like, do you think that even matters? And does it count as intracorporeal if you're completely lap, or if you do it through the fan and seal, that's extracorporeal, and does that clinically matter? I'm curious. And then the other thing is, a lot of these surgeons, it seemed like, were kind of adopting more hand assist. And so is there selection bias in the surgeons? And while I think this study was really well designed, do you think the surgeons are just faster at HAL because that's what they did more and what the practice consists more of? So I'll have you answer those questions, but great study.
Thanks, Tess. So also just to say, when we designed it, I went to the zealots and said, what data would you need? And John, if we go back a slide, what would you need to have a difference in length of stay or pain management? So I went and got all the data points that they said, well, you got to track pill counts, you got to track pain scores, you got to track all this stuff just to really show, and they really didn't see a difference. So I hope that the study showed that the outcomes were equal. Now they're even better now, 20 years later, than we were then. But I think the study was well designed and purposely designed so that those that didn't think the hand was a useful tool would appreciate it. The question of intracorporeal versus extracorporeal, if you do the anastomosis with the cover off of the gel port, it would be extracorporeal. If you put the cover back on to do it, you would call it intracorporeal, but it really doesn't make sense. And we already had randomized studies. There are randomized studies already for sigmoid colectomy, intracorporeal versus extracorporeal, showing no outcome differences. So I don't think there's a real need or a benefit of intracorporeal anastomosis if your incision is right over the anastomosis. And for the second part is, I think if you're a good open surgeon and you know how to use this tool, this wristed instrument, the original wristed instrument, I think you can be faster because it's like 5 tools instead of just 1 stick. And so with a wrist. And that's why I think if you're facile with this, you can be faster and you can avoid the complications. So complex procedures, total colectomy or bad diverticular disease, complex diseases, diverticular disease, inflammatory disease, or Crohn's, and then patients. And we'll talk about the next study, obesity. So I think the hand can overcome a lot of adversity. And if you get into bleeding, having your hand to put a sponge in and out really, really helps. And so I do still hand assisted today because I think there are benefits in certain populations, but even without it, there's still benefits. And I teach open techniques using hand assist with a laparoscope because I think residents today may not have all the skill sets of open surgery that I grew up with. And so I want them to have them. So I use it for dual purpose because I think there's benefit to the patient and I think there's benefit for education of residents who now need to learn a whole plethora of techniques in doing it.
Yeah,
John,
I mean, I think
your thoughts?
my two thoughts are, number one, from a methodology standpoint, I am really fascinated in these surgical studies. We're enrolling patients right now in COSMID, and so I'm getting to see what it's like to enroll patients in a national study. You read about the a la carte studies, you read about the ACZOG 6041 studies, you read about Puccini, you talk to the real life surgeons who actually enrolled patients in these trials. And now we have someone here who designed one of these trials. And so to me, I'm like, and then that's sort of the history of how that actually happened and like, how did you get the sites and like, where was everybody? You look at those names and you're like, where was everybody in their career at that point? So because I think this is what we need. These are the studies and data that we need. So I'm like, that's the first part in my mind that I look at that and I'm like, that's awesome. That's great that you guys did that. And, how can we replicate that with future studies? That's sort of number one. Number two is we'll get into a little bit with this next study. And then once we talk a little bit more about like practice patterns, to me, I think I am very grateful that I had that background in training with hand assist surgery because I think it just taught me so much about laparoscopy, about open surgery, about hand assist, and then eventually a lot of the same exact principles I use for the instruments at wrist, but happen to be docked on a robot. So all the same stuff and all the same principles. All right, so I'm going to talk about our next article. This is going to be laparoscopic colorectal surgery for obese patients, decreased conversions with the hand assist techniques. This was done and published in 2012. This was done at Cleveland Clinic. And Peter mentioned in certain patient populations, HALS may be beneficial. And so one of those patient populations is patients who have obesity. And so in this study, the authors looked to compare intra-op and post-operative outcomes of HALS and laparoscopic surgery in patients with obesity. So this was a retrospective study, so prospectively maintained database. Patients were enrolled if they had a BMI greater than 30 and underwent either hand assist laparoscopy or straight lap. They looked at a 5-year time period at Cleveland Clinic from 2006 to 2011. Conversion rate was defined as any increase in the length of the incision beyond what was routinely used to complete the operation. And then the groups, like I said, were compared on operative and post-operative outcomes. And then they looked at cases that were converted, cases that weren't converted. So for hand assist surgery, a 7-centimeter lower midline or low transverse or phalansteal incision was used for the hand port. Interestingly, and Tess pointed this out for the last study, that they didn't use right colectomy. So this study did use right colectomy, which I agree with what Tess was saying. I typically am not doing or saw hand assist right-sided surgeries, but they did for this case. They also looked at lefts and total colectomies and proctectomies. And then they described a little bit about their technique, similarly for how hand assist was defined, but then how straight lap was defined. And then all patients had the same uniform post-op pathway in regards to diet, pain management, and discharge criteria. All right, so they had 496 patients who met those criteria. 86 were hand assist and 410 were laparoscopic. There were 14 surgeons who were performing laparoscopy, 6 surgeons who were performing hand assist surgery, and only one of them routinely did hand assist surgery. The two groups were comparable in terms of patient characteristics, indications for surgery. And really the meat of the paper and the main outcome comes to conversion. So in the hand-assist group, rate of conversion to open was 3.5%, and then in the laparoscopy group was 12.7%. EBL was also significantly less in the HALS group compared to straight laparoscopy. Length of the incision was shorter in the laparoscopic group, 5.7 versus 7 centimeters. Who note that actually makes a difference. And then operative time and post-op outcomes were the same between the two groups. When you look at conversions, so there were 55 total conversions, 52 in the lap group, 3 in the hand assist group. Indications for conversion, there's no link between the diagnostic indication and need for conversion. The patients who underwent conversion, this is not necessarily surprising, had longer length of stay, increased OR time, and estimated blood loss when compared to patients who didn't have conversion. And then there was also higher morbidity without differences in mortality if you had a conversion to open. So the authors concluded that in patients with obesity, hand-assist laparoscopy increases the likelihood of a successful, minimally invasive operation without any real significant difference in length of stay. Some limitations of the study, retrospective, wasn't prospective as with the first study, so certainly could be influenced by some significant selection bias in terms of the type of technique that was used. They didn't control for some of the operative factors that, Tess had mentioned in the previous study. They didn't look at post-op pain. But all in all, it still is a good retrospective study that I think adds some important data to know and support its use in certain patient populations. So comments, gang, about this study in particular?
Yeah, I think it was a good study, especially in this time. And I think it's important to note that just about every study that's been done has shown fewer conversions in the hand assist versus straight lap group. And it's, why would you need to alternate? Well, bleeding or, a proactive conversion versus reactive. Bad adhesions, you can use a hand sometimes to help in certain areas. Small bowel obstruction with diverticulitis. I'll talk about that later. So there are things that you can overcome when you have a tool. I think the key is when you're really watching the video, for many parts, you don't see the hand. If you're seeing your hand, sometimes you got to wonder, am I doing the right thing? Like, I can't see. Usually your hand is in the way. So you do have to practice on some easier cases to gain the benefits in the harder cases. For obesity, I think what's fascinating is when we look at incision site, extraction sites, if you do a large male, their extraction site is going to be probably 5 to 6 centimeters. If you do it with a hand, for me, that's going to be 8. So is really 2 or 3 centimeters enough of a difference to make a huge difference in outcome? Probably not. I mean, and so, on average for a skinny patient, you may not need a hand, but for obesity, where you can't feel the vessels and that fat male mesentery cancer cases, I feel really good that I can palpate the IMA and then I can take it. And I can take my hand out and put a straight lap instrument in. So there's also versatility with the current things. And I don't think that comes out. Like it's just HALS. And I did a case yesterday. I don't know how to document it. I did some of it open. I did some straight stick and I put my hand in. I think the ability to change from one approach to another should be what every surgeon should be thinking about and not trying to classify it as one thing or another. It's minimally invasive surgery by whatever method. Tess, what are your thoughts in terms of this obesity and such?
Yeah, no, I think you bring up a lot of good points. I think I definitely, for that fatty mesentery where I'm doing it for cancer, I like to have my hand in there if it's really thick to be able to feel confident. And just like you said, sometimes I'll put my hand in, take the mesentery, and then take my hand out and just use a port through the, gel port and do straight lap, so going back and forth. I think in this study in particular, it'd be interesting to see a subgroup analysis based on the BMI. I mean, breaking it down 30 to 35, 35 to 40, et cetera. As we know, this was in, I think, 2012. Honestly, a BMI of 30 is like pretty normal now, and so it would be interesting as we're seeing, more and more of this to stratify, because I think of, a patient with a BMI of 30 a little bit differently than 45 in terms of their perioperative risks. I think this paper highlights the decreased conversion rate with hand assist, which we've talked about. And, both of these studies were short-term, not long-term outcomes. And I think one of the big things in terms of conversion that we, with laparotomy is, the risk of ventral hernia, which is, obviously for obese patients, going to increase morbidity. So, both of these studies looked at short-term outcomes, but there's also some long-term outcomes that we can think about as well.
Yeah, I think like we've been saying, I mean, we're obviously huge proponents of hand assist surgery, at least having that as a backup. I mean, it certainly could very well be your primary approach, and I think that that's great. For me, in terms of where I'm at right now in my practice, it's a fantastic backup approach. And so I'm primarily trying to, and I think mostly doing pretty much all elective minimally invasive abdominal surgeries robotic these days. But certainly my learning curve with robotic, one of the things that I felt very comfortable about was, okay, I'm gonna try and work on the robotic flexure, or the robotic like deep pelvic dissection, or taking a that Crohn's Medicine or whatever it is, knowing that I had that HALS backup, that I could salvage a case if I was concerned about something, or if I wanted to make a proactive conversion, and then be able to avoid a laparotomy. I mean, I think that that's a huge advantage, I think, in terms of patient outcomes.
Yeah. I remember in fellowship, you shared a paper with me, Marcello, that Dr. Tom Reed published, talking about the use of hand assist or peak port. So I think that's one of the things as I started in practice, is this patient, are they going to have a hostile abdomen with a significant inflammatory process? Should I just do this open? Do I even, dare attempt laparoscopy? Early on, I think I did a Hartman reversal and I just did it open. And, in retrospect, like, could I have done that lap? Maybe. And so I think this peak port paper helps to try to address this conundrum, where basically he describes making a small laparotomy incision big enough for a hand port at the beginning of the case, and basically right then and there determining, all right, this is not so bad, let me proceed with hand assist, or let's do the open laparotomy. And so I think it was 79 patients who had this approach. About half of them had immediate extension to the laparotomy, and the other half underwent hand assist laparoscopy, and only one of those who needed an eventual conversion. So again, just using this hand assist as a way to help triage patients, and maybe you can get that minimally invasive approach.
Yeah, and I think it's important to realize that you make a lower midline incision, we're going to need some incision anyways, whether it's that or a fan steel. And I think the thought of just taking a look to see, you can be surprised. And I think more of this could be done by acute care surgeons, maybe in their future. But also with the enthusiasm of robotics, everything's all about robotics. Well, if the flexure is hard, and I agree for both of you, like, you can be empowered to do more robotically because you have a tool to back it up. But if we don't train the next generation about how to use this hand as a tool for the backup, will it be okay? And we've looked at our recent experience in some other institutions, looking at outcomes of left colectomy, either robotic or hand assist. And those that started hand assist versus robotic, the robotic group did slightly better, maybe a half day to a day less length of stay, but had less splenic flexure mobilization. The hand assist group had more splenic flexure mobilization, but they seemed to do pretty well. But for those robotic cases that were more challenging, they almost all got converted to hand assist. And so I think the goal is avoid the midline laparotomy by whatever method. And maybe we should be doing more of this and helping our acute care surgeons, in that realm. John?
Yeah, and I think something that I didn't really appreciate when when thinking about making that initial hand assist port, whether that's a fan steel or lower midline, especially in the setting of prior surgery, is can you maybe even start with like a Verus needle and a 5 in the left upper quadrant, and then you look around that way, and that's your peak port, or maybe it's a couple extra 5s, and those are your peak ports. And even if you're going to end up making a fan steel, I mean, opening up an incision and then encountering, or opening the fascia and encountering adhesions is always a bit like nerve-wracking. So if you can start with under pneumoperitoneum and perhaps clear off those incisions so that you then make your lower midline incision, your phalansteal incision, knowing that the underlying bowel is well away, I think is a nice option to consider as well.
Yeah, I totally agree. And I've been doing that exactly like you say, John. So I think a lot of good tips for those listening. We kind of have alluded to this, but Marcello, I know you're teaching a lot of these courses for residents and fellows. Right now, are you doing courses for, practicing general surgeons or like ACS surgeons, like you've kind of mentioned, or are most of what you're teaching to residents and fellows?
Yeah, so it's really interesting that there's been now somewhat of a resurgence, realizing that this may not be so bad. 30 years ago in Europe, especially when we talked about hand assisted, they were laughing at us like it's not beneficial. Even for the fellows, we are doing now hand courses again because it's how do you split up the colon operations? Open, straight lap, robotic, and hand. And there are some programs where they're not getting exposure to hand. So we do courses for the fellows just so they have the tool. But what's interesting is that Dave Kleiman and I just went to Amsterdam because the European groups are realizing that they are not doing as well with laparoscopy as they thought. And so I think there can be a role, especially for our acute care surgeons, to learn some of the techniques for a hand Hartman. And that actually happened last night. A patient with a diverticulitis with an abscess in the pelvis had a small bowel obstruction. She was pretty ill going on depressors. And so the ACS surgeon asked me. So we made a 3-inch, 9-centimeter lower midline incision. And I was able to break apart the small bowel obstruction. We were able to suck out the abscess. And then I need to mobilize the colon. She had polycystic kidney disease. This is something that I would not have been able to challenge because of the SBO with straight lap. But I was able to do it with a hand with a 3-inch incision, bringing the stoma to the left upper quadrant. And so I think there can be more benefits teaching for some acute care surgery and avoiding the big hurt for this population. So it's interesting to see that there may be some swing back. And again, I think the goal is, John, I think is like a tool for the box. John?
We could go all night. We can keep going. We're here. We're here all night. All right. This has been a great discussion. Let's get some of our takeaways and we can wrap some of this up. So Tess, why don't you kick us off?
Yeah. All right. Consider using a peak port or diagnostic laparoscopy. HALS can be useful for those dense inflammatory process or patients with obesity. And before converting to laparotomy, might want to stick your hand in.
All right, Abelson's approach. I'm going to go next. I would strongly encourage those who are listening, if it's not already something that you know how to do, incorporate this into your toolbox. Okay, we need to be well-equipped surgeons and not just open surgeons, not just straight lap surgeons, not just robotic surgeons, right? You have to be able to modify your approach as needed. And so it's a great bailout, and then hopefully avoid a midline laparotomy. And then, yeah, you can certainly consider peak port, but then also, you can consider doing a varus needle in 3/5s, and try and get a sense of what's going on in there and what do you need to do. All right.
All right,
Marcello,
so
take us home.
Marcello knows, I think the goal is minimally invasive surgery by whatever method and means works for you in your practice. I think it works for complex procedures, total colectomy, just the time saving, and the colovesical fistula. Why not have a phalansteal right over it? Complex diseases, diverticulitis or Crohn's, complex patients, obesity, and bowel obstructions. And just a tip, if you're seeing your hand and you can't see anything else, you may not be doing it right. And so come to a course and we'll try to give you some tips and tricks to keep it out of the way. And remember that this is the original wristed instrument, but more than anything else, avoid the big hurt for your patients. Be a open-minded, minimally invasive surgeon and do what's right for the patient.
All right. time to wrap up. So if you like diving into the weeds, you can join us on our Sunday evening colorectal surgery virtual education series. Check out our show notes for some of the details. It's really been a privilege being able to be a part of this Behind the Knife team, creating content for you all. If you did enjoy this session, let us know. Leave a review. Last time, gang, as Behind the Knife says, until the next time,
Dominate the day.